Thank you, Ankita. Good evening, everybody. Good evening, dear faculty and dear speakers and attendees. A big welcome to all of you once again a Wednesday, and we look forward to the ICA webinars. And today is the 155th webinar, which is really tremendous and complimentary. And to begin with, today we have a very important lecture, a webinar, and this is the Indian College of Anesthesiologists, which I want to tell you that you can become a member. It's very valuable for all the young delegates, young consultants who would like to join this ICA. You can go onto our website and go and online and pay the prescription, the life membership, which is very reasonable, and become an ICA member. Now to go on next, we have Yearbook of Anesthesiology, which we are publishing every year. And last year we published the Anesthesiology Volume 12. And again, you can go on to this website, marypustak.com, and purchase them at a reduced price, very reasonable price. Please go ahead. The topics are extremely good. Dr. Mukul is our editor and does a very hard job. And the articles are very much appreciated. So this is the upcoming events that we are talking about. Again, today is, of course, the 5th of July, but coming now in November is the 4th International and the 14th National Conference of the Indian College of Anesthesiologists, which is going to be held in Bangalore on the 2nd to 5th November. And please go on to the website and get registered. So you are lucky to have the early bird registration. It's again going to be a very high level, high standard ICA con. Now, a very interesting, on the 12th of July, we will be celebrating our 3rd annual ICA webinar. So this is going to be the 156th webinar, and it's a very special one in which we are going to be presenting remarkable research publications right from the press. So this is going to be very, very interesting, and please do join. These are the details of the research articles that are going to be presented. They're going to be 8 from different journals, and we have very renowned moderators for it. And there'll be a very good discussion after this. And these are the latest articles that you can read over here from Anesthesiology, Indian Journal of Anesthesia, and Journal of Indian College of Anesthesiologists as well. Coming to today's webinar, which is the 155th one, today is another very, very important topic, although a little rare, but still very important, the blood disorders and aesthetic concerns. And for this, we have very special and very high qualified moderators, Dr. Manjula Sarkar, Dr. Bimla Sharma, and Dr. Sukanya Mitra. And of course, the speakers are all experts in their fields. Dr. Manjula Sarkar, very well known to all of us, especially in the Indian College fraternity. She was, of course, right now she is the professor and in charge of the Department of Thoracic Anesthesia in Mumbai, in the D.Y. Patil Medical College. Earlier, of course, she was the head of the department in another college, at KEM College in Mumbai. She has several publications and several national and international publications, and she has expertise in cardiac anesthesia. Dr. Manjula, could you please start the proceedings? And again, this is again the repeat. Dr. Manjula, please take over. Thank you very much.
Thank you, madam, for your kind words for the introduction. And I know that your smile and your introduction and your presentation is always really amazing for all of us. And it gives lots of inspiration for continuing this kind of the academic activities. So without delaying, I would like to say today's webinar is on the blood disorders and anesthesia concern, and you have already introduced the topic. And as an anesthesiologist, we are coming across with many times with such kind of the patient, those are having the bleeding disorders. as such, we have to manage the acute hemorrhage or acute bleeding. But when the patients are with bleeding disorders, the problems are little different. And if we are really prepared to manage those kind of the problems, and we know the anesthesia concern in these kind of the patients, then it is easy for us to manage the patients, and we can give the better outcome for the patients are concerned. So today's moderators are Dr. Bimla Sharma and Dr. Sukanya Mitra. Dr. Bimla Sharma is Vice Chairman, Institute of Anesthesia, Pain and Perioperative Care at Gangaram Hospital. Her area of interest is extraglottic airway devices, pain management. She is the founder, member, and trustee of the Fellow of Indian College of Anesthesiologists. And she is a regional coordinator of Indian College of Anesthesiology for Delhi and NCR division. She is guide and examiner for National Board of Examinations. She received a Bhojraj and Cops Award, and several national and international papers goes in her credit. Her today's second moderator is Dr. Sukanya Mitra. She doesn't need any introduction. She's very popular, very dynamic, and really doing very well in the academic career of her life. She is presently president of ICA Chandigarh branch, won many academic awards, Pain Research Fellowship, Pain Education Award, ICMR International Award, ICCM Research Grant Award, ISA Award, Rukmani Pandit Award, COPS Award, or many more. She has more than 100 scientific publications, invited book chapters, and her area of interest is acute and chronic pain management, cancer pain, palliative pain management, and pain education. So without doing further delay, I would like to request Dr. Sukanya to introduce the first speaker of the day. And over to you, Sukanya. Hello. Hello,
am I audible?
Yes, you are audible.
Okay. Thank you, Dr. Manjula, for your kind words. And a very good evening to all the delegates and all the respected teachers and the faculty members. So the first speaker of today's program is Dr. Pushkar Desai. He's going to talk about anesthetic concerns. And Dr. Pushkar Desai is a senior specialist from Sultan Qaboos University in Muscat, Oman. His area of interests are in different aspects of cardiothoracic anesthesia and regional anesthesia. He has many publications and has more than 20 national publications in national and international journals. He is also a recipient of number of awards. Dr. Pushkar was won the first in merit award in 2016 in DM cardiac anesthesia, and he's also a recipient of a number of other awards. So without wasting much time, I hand over the mic to Dr. Pushkar. Dr. Pushkar, please.
Thank you, Dr. Mitra, ma'am, for your kind introduction. Am I audible?
Yes, you are.
Am I audible?
Yes,
okay.
You are.
Yeah. Yes. So thank you, ma'am, for your kind information introduction. I would also like to thank Dr. Sarkar, madam, for giving me opportunity on behalf of ICA, and she's happened to be my teacher as well. So she has played a very big role in my career till now, and thank you, madam, for that. It's an honor for me to present a webinar in front of you. So the today's topic was allotted to me was anesthesia concerns in various blood disorders, but unfortunately our sequence of presentations have been changed because of some technical issues. So let me just tell you that our original first speaker was supposed to be speak on different blood disorders, and grossly she was supposed to speak on anemic blood disorders, bleeding disorders, and clotting disorders. So I'll just take over from that, and I'll just touch upon the important anesthetic points, and I will not go deep into the anesthetic management so as not to overlap for the subsequent lectures. So without wasting time, I would like to start my presentation. So grossly, blood disorders are classified into anemic diseases, then which includes commonly we encounter sickle cell disease, thalassemia, and G6PD deficiencies. After that, bleeding disorders, in which hemophilia and von Willebrand factor deficiencies, they are the most common in clinical practice, and then clotting disorders, which are also called as thrombophilias. Okay, so I'll start with sickle cell disease and anesthetic concerns. So sickle cell disease is a multi-system disorder, and when we say that multi-system disorder, obviously our concern should be tailored to each and every important system in the body. So we'll start with the cardiovascular involvement in sickle cell disease, and particularly we are worried about the high output cardiac failure in these patients along with LVH hypertrophy. Often these patients also have myocardial infarctions without presence of coronary artery disease. In respiratory system, these patients usually presents with acute chest syndrome with pulmonary hypertension, and they have restrictive lung function. So accordingly, our anesthetic management should be tailored. Then for renal tubular pathologies, these patients have got renal infarction issues. These patients also sometimes they have undergone splenectomy so that their immunity is hampered. So we have to take the proper antibiotic prophylaxis during perioperative period. Then transfusion related complications. These patients in their lifetime have received tremendous amount of blood, right? So we have to be worried about iron overload in these patients, aluminization, and also transfusion associated viral diseases should be screened before any surgery. Our most important thing is to prevent the factors which precipitates vaso-occlusive crisis in these patients, because these patients are prone for acute perionychosis and acute chest syndrome. These patients have got chronic pain issues, and because of this issue, these patients or these subsets, they are at the risk of opioid tolerance. That's why multimodal analgesia is of prime importance in this kind of patients. So when we say that our main aim is to avoid the precipitant of sickle cell crisis, that is during the perioperative period, we try to avoid the hypoxia, hypothermia, any vascular stasis, okay, and metabolic or respiratory acidosis. And that's the only reason why we avoid prolonged fasting in these kind of patients, and these patients should be posted as a first case during the day. Tourniquet. It's very important because these patients often undergo orthopedic procedures, and tourniquet should be avoided as far as possible because it leads to the occlusive crisis because of venous stasis. Then hematology input, because all these blood disorders, in all kind of disorders, hematology input is absolutely essential. These particularly pertaining to sickle cell disease with hydroxyurea, which increases the hemoglobin F concentration and avoids the sickle cell crisis during the perioperative period. So hematology input can help to 30% depending on the type of surgery and the age of the patient. And while exchange transfusion is routinely not indicated, it is indicated when patient is severely hypoxemic and patient is at risk of progressive acute chest syndrome. And if patient has a previous history of any ACS or pulmonary hypertension, then exchange transfusion is indicated. Also, if the hemoglobin S concentration is more than 30%, exchange transfusion has to get it down to less than 30%. Now, coming on to thalassemia. So, thalassemia is just abnormal beta globin synthesis disorder, so that these patients presents with hemolytic anemia as well. So usually this is also a multi-system disorder, and sequelae of multiple transfusions and iron overload should be kept in mind in these kind of patients. These patients have restrictive lung function, pulmonary hypertension, impaired glucose tolerance, then aluminization, and of course the blood-associated viral diseases should be screened. Then particularly in thalassemic patients, there is extramedullary erythropoiesis. So that leads to maxillary overgrowth, and this leads to difficult airway. Also, these patients have got high arch palate, and in those patients, the LMA insertion is usually difficult and challenging. So hemochromatosis. So it's basically deposition of hemosiderin in the tissues, and here we are particular about cardiac involvement in hemochromatosis, which leads to dilated cardiomyopathy and heart failure. Also, these patients are prone for any conduction delays and torsades Q pointis phenomenon. These patients have got thinned out cortical bones, so regional anesthesia poses a great challenge in these patients. And also during perioperative period, you have to be very careful during the positioning of this patient so as to avoid the bone fractures. Both general anesthesia and neuraxial anesthesia are safe in sickle cell as well as thalassemia patients. Coming to G6PD deficiency, all the concerns are same here also, but main aim is to avoid the oxidative stress like hypoxia, hypothermia, acidosis in the perioperative period. An important thing to remember is to avoid certain common drugs which can potentiate the G6PD phenomena, like acetaminophen, acetyl salicylic acid, antibiotics like ciprofloxacin, nitrofurantoin, and anticonvulsants like phenytoin and sulfa drugs. So this should be kept in mind. Coming on to the bleeding disorder subset, so we'll start with hemophilia. So hemophilia is perhaps the most common bleeding disorder, inherited disorder. Then here also multidisciplinary team along with hematology support with occupational therapist and physiotherapist support is absolutely essential during the surgical planning. Also, you have to be liaise with the blood bank services to ensure that the adequate supply of the factors are available. So that's very important. Regarding surgical time slot, all these patients are high risk and we need multiple people support. So this patient should be preferably posted as an elective case during the as a first case during the routine list. Then these patients are prone for bleeding. So for anesthetic point of view, we have to avoid any kind of mucosal trauma, and that we can avoid during careful endotracheal intubation, nasogastric tube insertion, and we have to adequately lubricate the tubes, and when we use Magil forceps, we have to use it very gently. Also during suction, non-traumatic suction catheters are preferred over the blunt suction catheters. Then positioning, your pressure points are padded during surgery so as to prevent the extremities to prevent intramuscular hematomas and hemarthrosis. Also in this kind of patient, any kind of intramuscular injections should be avoided. So regarding succinylcholine in hemophilia, so concerns have been raised like choline-induced muscle fasciculations might worsen the muscle and joint hemorrhages. So these concerns have been raised, although there are multiple case reports where it has been used safely, but it has to be kept in mind. Regarding Invisalign monitoring, in these patients, preferably you try to avoid arterial or central line cannulation blindly. Even if you want to do it, always the ultrasound guided access should be performed. Then regional anesthesia in hemophilic patients, although there are no clear-cut guidelines available, there are case reports available with the factors a factor 8 or 9 within normal range. The safe neuraxial anesthesia have been performed for hemophilic patients, particularly in orthopedic joint replacement surgeries. Regarding pain management, multimodal analgesia is recommended, but the important thing is to avoid the non-steroidal anti-inflammatory drugs in these kind of patients. And DVT prophylaxis with early mobilization is indicated. for early recovery. Regarding specific interoperative management for factors, 80 to 100% factor 8 level is considered safe during perioperative period, and postoperatively it has to maintain for 6 weeks for patients undergoing orthopedic procedures, and for other surgeries up to 2 weeks, the same level should be maintained. Von Willebrand disease, it's the most common inherited bleeding disorder. So in this case, nothing much important except that pharmacological management is sufficient in majority of the cases. And we have to keep the 1 Willebrand factor and factor 8 level around 100 international unit per deciliter perioperatively. And DDIVP is indicated in type 1 type of 1 Willebrand disease, and it should be given around 60 to 90 minutes before surgery. And here the hematology consultation or input is advisable. Coming on to immune thrombocytic purpura, it's the autoimmune disorder of the platelets, and in these cases usually responds to platelet transfusions, pulsed doses of steroids like dexamethasone, then IVIG, and then rituximab, and sometimes splenectomy to increase the platelet survival. And neuraxial anesthesia is contraindicated in these kind of patients if platelet count is less than 50,000. And for major surgery, more than 70,000 platelet count is advisable, and for neurosurgery, more than 100,000 platelet count is recommended. Coming on to the clotting disorder, which is basically in a exaggerated coagulation because of excess procoagulants or deficiency of anticoagulants like protein C, protein S. These patients usually have thrombotic and embolic events, which leads to cardiopulmonary involvement, particularly in pulmonary hypertension. And in cardiac, these patients usually present with valvular dysfunction. The important point in the during perioperative period is to avoid any factors which precipitates the risk of deep venous thrombosis, and that's why pre-surgical placement of IVC filter, especially before any major surgery, is sometimes indicated. We have to avoid prolonged fasting and avoid dehydration in these kind of patients. Also, we have to have early mobilization with the use of mechanical pneumatic devices for DVT prophylaxis during perioperative period. And here also a multidisciplinary team, including physiotherapists, play important role in early mobilization of these patients along with multimodal analgesia. Then these patients often they are on warfarin or anticoagulants. So accordingly, as per the surgical need or the emergency, bridging therapy using unfractionated or low molecular heparin should be instituted judiciously. And regional anesthesia guidelines, we have American and European Society of Regional Anesthesia Guidelines. They have very clearly mentioned timings before any anticoagulation. So it has to be followed strictly. So to summarize, in all blood disorder, multidisciplinary team involvement is very, very important, and it's absolutely essential. It's a teamwork, and you have to involve the blood bank as well. Then if it is an elective surgery, patient has to be fully optimized, and early use of ultrasound is indicated. Blind use of central venous cannulation is not advisable in these patients. Multimodal analgesia is essential, and these patients, because of frequent hospitalization, they are at the risk of opioid tolerance. So we have to keep this in mind. Thank you very much.
Thank you, Dr. Desai, for that interesting lecture. And more so, I thank you for keeping the time very, I would say, punctual about keeping the time. Thank you so much. We'll take the questions at the end of the session. So we go on to our next speaker, who is Dr. Rachna Wadhwa. And she's going to talk about optimization and perioperative care in blood disorders. So Dr. Rachna is an associate professor in GB Pant Hospital, New Delhi. Her areas of interest are perioperative management of cardiac patients, TE, point of care ultrasound, teaching and training students in anesthesia and trauma and intensive care unit. So Dr. Rachna has more than 50 publications to her credit. She is a faculty of many national events and received more than one award to her in her career time. So without wasting much time, I hand over the mic to Dr. Rachna. Dr. Rachna, please.
Just a second, ma'am. I'm just sharing my screen.
I think, Dr. Rachna, I've already introduced you, so you can straight away go to your talk.
Okay, ma'am. Is my screen visible, ma'am?
Yes, yes.
So my screen is visible, ma'am?
Your first slide is visible.
Yes.
Yeah, it is visible now. Yes.
Okay. Thank you, ma'am. Thank you for the kind introduction, ma'am. And though perioperative care, a part of perioperative care has been taken up by the previous speaker, but I will go on detailed kind of optimization for all these disorders which have been discussed. So I'll deal about the perioperative management and the specific care and monitoring with respect to TEG, ROTM, and the optimal use of blood products in all these scenarios. So it is very challenging. It is multimodality and multidisciplinary approach, which is like patient-centered. All patients are different. And we must know what is the systematic and evidence-based approach to improve all these patients. Techniques and strategies for optimal management, they span the entire perioperative period. That begins from the preoperative assessment until the patient is discharged from the hospital. So the spectrum is like all the disorders of RBCs, WBCs, platelets, the coagulation disorders, the anticoagulation related coagulopathies, the disease related coagulopathies, miscellaneous, sepsis-induced factors, and all these factors. So I begin with the inherited bleeding disorders, which are like hemophilia A, that happens because of factor A deficiency, and it is found in 1 in 5,000 male births. Hemophilia B is because of factor 9 deficiency. Hemophilia C is because of factor 11 deficiency. Von Willebrand disease, which happens in 1 in 10,000. Then we've got rare bleeding disorders like deficiencies of factor 2, 5, 7, 10, and 13. And another entity called dysfibrogenemia. However, hemophilia and Von Willebrand disease, they are the most common, and I'll be dealing with these two mainly. So to begin with the preoperative assessment. So if we have a patient that is suggestive of like any bleeding disorders, we must take a detailed history. Generally, the parents tell that the child bleeds even with small trauma. The child bleeds even with small trauma. Hello. Or at times, whenever we take a history, then the females, they give excessive bleeding during menarche. So we must take detailed history to screen what type of hemophilia is this, what kind of Von Willebrand disease is this, the severity of disease. We must have private information about what was the response to desmopressin, use of recombinant factors 8 and 9, or previous transfusion of blood. We must take a meticulous look at the biochemical profile, like complete blood count, coagulation profile, fibrinogen levels, and specific factor assays, if at all they are indicated with respect to history, previous history, and records. All patients must be evaluated for the presence of transfusion-related infections such as HIV, hepatitis B and C, just because they would have received the transfusions and they are at high risk of all these infections. They could have bled in their joints, which could have led for joint deformities, contracture, and thorough airway assessment, as my previous speaker has already told you. So the goals are multidisciplinary management, and what is important is role of hematologist. So hematologist should always be like in the loop for the preoperative optimization, when to take up, what are the goals that are very important to achieve that level in which the patient will not bleed more. Of course, surgeon, anesthetist, and occupational therapist may be needed later on. And whenever we are taking such case, we must ensure that appropriate factor concentrates are available in the hospital. Elective surgery should be scheduled preferably in the morning, and preoperative clotting screening specific factor assay should be done. And if at all we have to go for preoperative transfusion of recombinant factors, then it has to be 30 to 60 minutes before the surgical procedures. I think practically this is very important, and all of us should know that, like factor 8, if we are supposed to give factor 8, the T half may be like, say, 8 to 12 hours, but it is generally given just prior to the surgery. Even for the factor 9, even if the T half is like 24 hours, we generally give it prior to surgery in all these cases. So this has already been dealt with by my previous speaker, that we must avoid the mucosal trauma. What is very, very important is maintenance of normothermia. We all know that the lethal triad includes these coagulation deficiencies, acidosis, and hypothermia. So these three things, they have to be taken care of whenever there is a role of perioperative management. Just because the temperature has to be there, there should be no acidosis, and obviously we know that the patient has bleeding disorders. So we should avoid all those precipitating factors that can lead to increased bleeding. Pressure point care, whenever we are positioning, we should be very, very careful. As already discussed, we must use ultrasound guided intravascular, internal jugular or central line accesses, and for arterial access, avoidance of tachycardia, hypertension, and all these factors, avoidance of NSAIDs for post-operative pain management. So now specifically coming to management of hemophilia, we all know that when the factor 8 levels are like less than 50%, so we just label it as hemophilia, and the normal levels may range from 50 to 150%. But for correction, it is very important that the levels should come around 80 to 100%, and we have to maintain these levels for like up to 2 to 6 weeks, depending on the type of surgery. So recombinant factors 8 and 9, which are like used in hemophilia A and B, they are infused. Normally, what we do, we use 75 to 100 units per kg of body weight for hemophilia A. And I've already told you, but this transfusion will raise by only 2%, and T half of factor 8 is 8 to 12 hours, or factor 9 is 18 to 24 hours. So for just because it is like 12 hours, we multiply the weight of the patient and desired level with 0.5, and in factor 9, we just multiply the weight of patient along with the percentage factor level desired. However, very important is we've got different kind of responders, and that depends upon the presence of inhibitors present. Like I don't know means, but yes, suppose I'm talking about diabetes. So we know about that the patient's circulating insulin levels may be high and there is resistance. So it is something like that, the patients, they are different responders depending upon the amount of inhibitors present. And the level of inhibitors that are present, it is measured in Bethesda units. So if like the Bethesda units are 5 or like, so these are low risk, and they will accept the factor 8 readily and will respond to it. So one has to look for the level of inhibitors also. And if I am specifically giving factor 8, then it is like intermediate and high purity factor 8 concentrates. I am dealing with all these factors separately, just because most of the times and in most of these setups, the approach is generally blinded. people just start giving, the patient is bleeding. People just start giving FFPs. And then we may give cryo, and then we may give platelets. Just thinking that all these blind therapies will aim at one thing. But something that will work is the specific factor that is missing. So it is very good to diagnose what is deficient and hit the target with the cause. Means the cause has to be treated for appropriate management. That is why we need to know the deficiencies of the factors and the hit management of these. So cryoprecipitate, which we generally use as source of factor 8, Von Willebrand factor, factor 13, and fibrinogen. But yes, we must know that they still have risk of blood-borne infections transmissions. And prothrombin complex concentrates, they are also used as they're very good. They have combinations of protein C and S also, but they are generally not available. So one has to see. Recombinant factor is available, but then yes, it is very expensive. And one has to tailor-made, yes, that it is a proven factor 7A deficiency. Then only we should be giving it. FFP is no longer used in the perioperative management of hemophilia, as it carries the risk of blood-borne infections and volume overload. I've already told you why not to give blinded therapy in these patients. So desmopressin plays, it's a very, very important kind of analog of vasopressin hormone, and it forms a complex with factor 8 and it prevents its breakdown. Still, it is used only in the mild forms of hemophilia A and Von Willebrand disease, and it is ineffective in severe hemophilia. The peak effect of IV dose is 60 minutes, though we have used it intranasally also, and the dosage is like 0.3 milligrams per kg, but it has to be titrated again, and its use is still not approved in less than 2 years and in pregnancy. I think tranexamic acid and hemostat, that is YACA, is like used worldwide, and it can be used orally also. It can be given IV also. Plasma half-life is 2 hours. And most of the bleeding patients will be receiving the Tranexa preoperatively also, and during the surgery it is generally given in the what we use is 10 to 15 milligrams per kg body weight initially. For hemostat, we use 100 milligrams per kg of body weight for all the patients who are going on bypass. So the dose can be like 50 to 100 milligrams for hemostat, and for tranexamic acid is like 10 to 15 milligrams per kg body weight to begin with. Now coming to Von Willebrand disease, the majority, they do not need blood components to control hemorrhage, and it is only the pharmacological management. You just have to weigh the high risk subtypes. When there is a high risk, it is recommended that we must have all these levels, and the levels they have to be maintained for 100 IU international units per deciliter, and the concentration should be 100 international units per deciliter to cover the major surgeries. Yes, pharmacologically, I've already discussed that we can use the desmopressin in all these cases, and antifibrinolytics like Tranexa and hemostat will work well. Though we still have Von Willebrand factor and factor 8 concentrates, and they can be used when the patient is not responding, and we may add on platelets also, because if the bleeding is persistent despite desmopressin and Von Willebrand factor concentrates, there is additional need of platelet transfusions. Regional anesthesia, ASTRA guidelines should be followed for all these coagulopathies. Now, obstetric patient with hemophilia. Now, this is very important because females are usually carriers, as hemophilia is an X-linked recessive disorder. So all female patients here, relatives should be screened, and once the carriers are identified, they must be educated and counseled about the risk of having a child with hemophilia, and other reproductive options should be given. Such patients should be managed with multidisciplinary team right from the antenatal period, and it is recommended that the sex of the child should be known, though like it is banned like with PNDT. But for all these disorders, it is important so that the child born with hemophilia should be known to the parents. And factor 8 and 9 levels, they have to be maintained above 0.5 international units per ml even in the postpartum period. Now, what about the mode of delivery? Whether they should go for vaginal delivery, whether they should go for cesarean section, it is like very difficult, and it is a debatable topic. But even if the parent is undergoing normal vaginal delivery, the prolonged labor has to be avoided, and the forceps delivery, it should be instrumental delivery, it should be avoided. Now, recessively inherited coagulation, we may have deficiency of fibrinogen, prothrombin, and other clotting factors, which are like rare, but still presently we have got many concentrates which will take care of them. So other inherited clotting disorders that were discussed, like thrombophilia, when you've got excessive procoagulants and the patient is already on anticoagulants. So one has to look into them also. So again, that detailed screening, detailed coagulation, and hematologist consultation, and when to give FFP, the timing and the indications are again very important. It is again multidisciplinary team, and we must have ultrasound, we must have multimodal analgesia, and if these patients still need anticoagulation, we must go for unfractionated heparin, and we must measure the factor Xa levels, which is like very important. Now one has to weigh whether to give general anesthesia or to go for regional anesthesia, depending on the severity, depending on the grading of the bleeding disorders they have. I think one of the most important part is the consent. The patient should be told about all the modalities, all the complications, and should be given the choice for all. So that way we will be like in good consultation with the patient, and about all the medical legal issues that will rush in once there are any complications. So in intraoperative strategies, as I've already told you, the presence of normal temperature, minimally invasive surgical techniques, intraoperative blood salvage techniques, if we have got use of cautery, decreased bleeding, topical hemostatic agents like T-seal, tissue adhesives, use of preoperative systemic use of Trinixa, hemostat, desmopressin whenever required. And if there is a specific deficiency known, we must arrange for all those clotting factors. Now, one of the most important steps that come is like prothrombin time, the coagulation monitoring means what all we are doing. Is it effective? Are we targeting
Dr. Rachna, sorry to interrupt. I think you've already shot over the time. So,
okay, ma'am. Okay, ma'am. I will just rush through. I have got only the 2-3 slides of coagulation monitoring.
No, Rachna, you just conclude.
Yes, okay, ma'am. So I think TEG and ROTEM are the standard cares of management for which we must go. The TEG was used initially, but it takes a lot of time. And ROTEM is like targeted therapy, and we must go for ROTEM. That is the need of the hour. Thank you, ma'am.
Thank you, Dr. Rachna. That was a very interesting and very clinically oriented lecture. I'm sure the students will be hugely benefited, like if they listen to you carefully. Thank you once again. And we'll have a question answer session at the end of this, all the lectures.
Thank you, ma'am.
Okay, I hand over to Dr. Manjula for introducing our first speaker.
Thank you, Sukanya. Now, third speaker of this webinar series is Dr. Sweety Purushotham, and she's holding the position of Assistant Professor at the Department of Anesthesia at D.Y. Patil School of Medicine, Navi Mumbai. Her area of interest is interventional spine, complex pain. She has done fellowship in interventional pain medicine, fellowship in advanced regional and trauma anesthesia. She's a speaker and faculty for many pain conferences, affiliated with many medical officials, and she has many publications in her credit. She has attended many conferences. First prize for the quiz was in her credit, and she's going to talk about the various disorders, bleeding disorders. Those patients can come to us for the emergency explorations or for the elective surgeries. So over to you, Sweety. Please carry on.
Thank you, ma'am. Very good evening to everyone present here. I am really grateful to ICA for conducting the need of the hour topic and also for inviting me to be a part of this. I hope something we discussed today would be very helpful in our practice in the future. So let me move on quickly to what are the blood disorders that we commonly come across in operative patients. To understand that, we need to, yes, please, next slide. We need to go into the journey of our renowned William Harvey, whose principles we still follow. He said that if we have to understand or move forward from traditional medicine, we need to really understand the concept of the circuit of blood. So what does that mean? Next slide, please. Now, blood, it has various roles in our practice in the human body. It is not just a form of component which transports metabolic products, carries oxygen, gives nutrition. It has many other roles. It also is very important, vital factor for maintaining life. Any disorders of blood can cause loss of life to the most critical part. Next slide, please. So if I break down blood, I need to understand what it is. Why are we talking about different components? From all the past speakers, we would have understood how our management depends not just on the condition, on the investigation, it also depends on understanding what the patient is presenting to you. So it is most of these patients who come with blood disorders have some or the other genetic, hereditary, or nutritional component. So it is very vital that we include that in the history taking. If we break down blood, it has a solid and liquid component, which are equally a part of it. In solids, we take into consideration RBCs, WBCs, platelets, and in liquid, there is plasma. Plasma, it comprises of various salts, water, and also proteins. So the components, if we further go ahead, there are multiple more parts that we need to understand. Next slide, please.
Hi,
Next slide. Yes. The most commonest
Ma'am,
blood
just a little
disorder.
interruptions, ma'am. I'm muting everyone so that nobody, there's no glitches, ma'am, and you can unmute yourself once you speak. Okay?
All right.
Yes, ma'am. You're kindly proceed.
Okay. So one of the commonest disorders we know is anemia. Whenever we think of anemia, we usually go into a CBC count of hemoglobin being between such and such range for males, for females. Rather than that, anemia in the scientific term, it means that it is it is a lack of oxygen carrying capacity of that particular red blood cell. So it is commonly in a clinical condition. These are the different types of anemia that we know of. Iron deficiency anemia, where the iron component is less. So the heme part, it is reduced and it shows a microcytic picture. Then there is megaloblastic anemia. Then there is pernicious anemia. Pernicious, again, it can be nutrition based. And there is hemorrhagic with all the bleeding disorders or bleeding conditions where there is loss of volume, which again leads to loss of red blood cells and other blood components. Then there are hemolytic anemias, which can be due to some genetic disorders. And there is something known as aplastic anemia. Now, when we look into blood disorders, we need to understand there are various areas where the blood disorder can present. It can present at the production itself, so bone marrow, depression of bone marrow, or some bone marrow disease, which can lead to aplastic anemia sort of a picture. It can be one of those components which lack, which can lead to anemia, or it can be also during the conduct. So any blood vessel disorder can lead to anemia or some blood disorder, or at the part where the transformation of the blood occurs. Next slide, please. Next slide. This is the various anemias. We have spoken about the clinical part. Now I'll speak about the mean corpuscle volume. So it is divided into microcytic, normocytic, and macrocytic. In microcytic, these are the anemias that we see. Next slide. In normocytic, we have using corrected reticulocyte count, we have the anemias which present due to intrinsic RBC defect, which are mainly hereditary, like sickle cell, G6PD deficiency, pyruvate. Then there is extrinsic RBC defect, where the blood loss more than 1 week, it usually shows, or there's some hemolytic anemia or malaria-like condition. And the other one is blood loss less than 1 week, early stages of anemia, aplastic anemia, renal diseases, malignancy. Another factor we need to understand is the blood disorder can also be related to cancer, where there is destruction of blood components, also related to diseases, chronic infections, inflammatory bowel diseases, where there is lack in formation of other components required to form blood. Next slide, please. In macrocytic, we again divide it into megaloblastic and non-megaloblastic. Megaloblastic, again, it depends on folate and vitamin B12 deficiency. Whereas non-megaloblastic has other secondary causes like liver disease, alcoholism, drug-related, and reticulocytosis. Drug-related, now it can be iatrogenic also, because most of these patients are, not most, there are some patients who are on antiplatelet drugs, on blood thinners, or there are drugs used to prolong the clotting. Next slide, please. Now, another major factor of a blood disorder is clotting disorder. Let us understand it in more detail. Next slide. Now, why clotting disorder? What happens when the normal vessel gets an injury? The injured vessel has a collagen component on its wall, which attracts the platelets, which is transmitting through the blood vessel. Now, these platelets will aggregate or stack on top of each other, which is known as primary hemostasis. And this will form a temporary plug or a clot. Now, this temporary clot, there is another mechanism. Now, we have intrinsic has already started. So there's another extrinsic where the clotting factors are involved. They get involved, they activate clotting factors, and they form a fibrin clot. This fibrin clot mixes up with the temporary plug of platelet and forms a proper plug, which prevents any other leakage or entry of infection. Now, this further, there is a remodeling of fibrin so that the normal tissue or the healing takes place in place of injury. Next slide, please. Next slide. Now, this is in short how the phases are divided. There's a vascular phase, the platelet phase, coagulation phase, and remodeling phase. We'll go further into detail on how this pathway of coagulation takes place. Next slide. Now, this is one slide that all of us has been trying to memorize, and we keep on repeating it in our medical literature. It's very important to know the first four factors, that is factor 1, fibrinogen, factor 2, prothrombin, factor 3, which is thromboplastin, and factor 4, which is activated calcium. And there is factor 9, 10, and 12 that you need to know: the Christmas factor, the stored power factor, and Cageman's factor. Now you see the cascade. This is a little confusing, so I've broken it down into much more simplified algorithm. Let's move to the next slide, please. Yes. In this, if you note, there are two pathways which is merging together at X point. X point is factor 10. Now, if you see the intrinsic pathway where the vessel injury has taken place, so collagen it is activating, right? So factor 12, factor 11, and then you need a factor 8 and calcium to activate from 9 to 10, and they merge together. Again, extrinsic pathway where the clotting factors get activated, factor 3, factor 7, they merge together. They activate the prothrombin, which again forms a thrombin, and the clotting mechanism starts by activating platelets and fibrinogen. Now, all this further requires activation of factor 5, 7, 8, 11, and 13. This is a simplified version. It is much more easier to remember. Next, please. Now, what are the other clotting disorders? Now, clotting, if it is done right, it is really good. But if it is done, if the clotting cannot be stopped, it can cause hypercoagulable conditions, which is again harmful. It can lead to stroke, deep vein thrombosis, myocardial infarction, pulmonary embolism, and the causes can be various. It can be from genetic, it can be cancer, some deficiency, some gene mutation, or chronic inflammatory bowel disease, sepsis. Usually we see in sepsis patient there's further hypercoagulable conditions. Next slide, please. And hypercoagulability, where there is lack of clot formation, which leads to bleeding disorders like hemophilia, which different types we have seen from the previous speaker, Von Willebrand disease and thrombocytopenia. Next slide, please. And the vessel, now, if we commonly see the other factors which cause blood disorders, we see that there are vessel wall defects. Now, vessel wall defect, again, it depends on the integrity of the vessel structure. And that can vary from a child to an adult to an elderly. It can also vary depending on the genetic condition. The other factors are deficiency of vitamin C, which we need to know commonly in children, scurvy, which we often tend to miss out in our PACs, because, and there are some clinical signs of scurvy that we need to know, and they have other collagen deformities also. So it is not just one particular intrinsic blood disorder. There are other factors also that we need to see. And patients on chronic excessive corticosteroid intake, they usually have a general protein wasting and atrophy of the connective tissue. So this also leads to a vessel wall defect, most commonly like in Cushing syndrome. Next, please. One common disorder that we all need to know is DIC, because the patients who present to us need not be an elective case. They come from ICU, they come in emergency situation, there are trauma patients who come. And we also, our blood transfusions can vary from 1 or 2 blood components or blood packed cells to multiple blood transfusions. So we need to understand DIC is a very crucial condition. It can be acute, subacute, or chronic. And it is characterized by excessive activation of coagulation, which leads to formation of thrombi in the microvasculature of the body. Now, next slide, please. And this is in short of a collection of platelet disorders that we need to know. In that we have thrombocytopenia, which can be because of less platelet survival. Now, each of these blood components have a cell cycle. If they have to remain for a certain period, there are some mechanisms which can destroy it earlier, or whether the component can survive it or not. It can be mainly related to immune-mediated conditions or collagen vascular diseases, or it can be a drug-induced. Or other factors like hemolytic uremic disorder, DIC. And now this is about the survival. Production, it can be, there can be a decrease because of malignancies like leukemia, sepsis, which can be both viral and bacterial, and or platelet sequestration problems, like in a congenital splenomegaly, or there's some disorder leading to hemangiomas. Also some syndromes which is there from congenital acquired disorders. And there are other factors which can also be congenitally present, like hemophilia and Von Willebrand disease. Next slide, please. Investigations has been dealt in detail by the previous speakers. I'll go through the common ones that we need to know. Other than our complete blood profile, we need to go for platelet count, bleeding time, prothrombin time, activated partial thromboplastin time, and fibrinogen concentration. Because each of this gives much more detailed understanding of different condition as well as factor deficiencies. And there are further tests that is required. Next slide, please. Like we all have been commonly been telling, we need a multidisciplinary team. Usually there is, we are the primary physician who is dealing with this patient, but then there are other doctors also involved in this team. The general physician, if it is a congenital, who has been following up with that child or adult. The hematologist for further understanding of complex disorders and management of it. And the surgeon, of course, because it's a teamwork. We all are operative doctors. Next slide, please. So this is my summary. The blood, it may be a simplest thing which we all have or we all share, but it can really create a huge difference in one's life. So kindly donate, and that's all from my side. Next slide, please. Thank you. Thank you, everyone.
Thank you, Sweety, for giving us the elaborative and explanatory causes of various bleeding disorders, which we are really concerned for as an anesthesiologist, and what is the mechanism of the different bleeding disorders. Now, I would like to hand over the mic to Dr. Sukanya for introducing the next speaker.
Thank you, Dr. Thank you, Dr. Manjula. As the next speaker, is the next speaker sharing the screen?
Yeah, hi.
Hi.
I'll share the screen, madam.
Okay. So our next speaker is Dr. Shilpa Tiwaskar, and she's a faculty at Bala Venkat Hospital in Mumbai.
Bhaktivedanta Hospital.
I can't read from here. Okay, sorry about
Yeah.
it. I'm in Mumbai, and Dr. Tiwaskar is a member of number of committees and executive member of number of bodies. She's her areas of interest are critical care, airway, regional anesthesia, and resuscitation. She has a number of publications and one book chapter and reviewed multiple journals. She's going to talk on excessive bleeding and its management in blood disorders. Now, this is a very important and permeating topic for our clinical every day-to-day practice. I hand over to Dr. Shilpa Tiwaskar for her talk.
Thank you, Dr. Mitra, madam, for the kind introduction. At offset, I would thank Indian College of Anesthesiologists and Manjula Sarkar, madam, for giving me this opportunity. Hope I am audible. Yeah. So
yes, you are.
Yeah, my talk would include which precautions to follow when there is excessive bleeding, when to get alerted, which protocol to follow, and how to prevent complications. The first and foremost, which we learned during our PG days, is calculate the estimated blood volume for each patient. As we see, for an adult male, it ranges around 70 ml per kg, more in neonate and infant, but as the body mass index increases, the ml per kg decreases. Now, why we need to calculate the estimated blood volume? So that for each and every patient, for even ASA grade 1 patient, we need to calculate the allowable blood loss. How much? Because sometimes we tend to underestimate the blood loss. So it is, suppose if you see the example below, in most of our scenarios in private practice, we may not get the hematocrit level, but we definitely have the hemoglobin level in our hand. So for a 60 kg patient, if you see, and 70 ml per kg, if I calculate the blood volume, and always I would like hemoglobin to be 10 gram%. So the difference between the actual hemoglobin of 12 and the 10 which I expect is 2. So if I calculate for a normal 60 kg adult patient with 12 hemoglobin, my allowable blood loss is only 700 ml. So what does our anesthesiology book say? that unless the danger of anemia outweighs the risk of transfusion, till then, please do not transfuse. Now here, what is the definition of excessive bleeding or severe bleeding? I have also put the definition of massive transfusion for us to understand that blood loss exceeding just 1000 ml or blood loss more than 25% of the patient's blood volume is considered as excessive bleeding, and it is not when we require massive transfusion. Now, what precautions can we take? Some precautions beforehand? Yes, as I said, for each and every ASA grade 1 patient also, please calculate the allowable blood loss, which is allowable for that patient for age and weight. Then initiate the trigger early. Be vigilant. Do not wait till 25% of the blood volume is lost. Use restrictive protocol only in ASA grade 1 patient, hematologically normal patient, and if the patient is having bleeding disorders, coagulation disorders, or on anticoagulants and antiplatelet history, though it is stopped, your triggered should be early. Now, the conditions which should alert when you are going for those surgeries, giving anesthesia for those surgeries, for pelvic surgeries, obstetric surgeries, GI bleeding surgeries, for abdominal aneurysm surgeries, liver laceration, CABG, neurosurgery, transplant, you should be alert that you might require to give blood and blood products early. A footnote that for intracranial surgeries, spinal and ophthalmic surgeries, sometimes the platelet transfusion trigger might be less than just 1 lakh. And desmopressin should always be ready. Now, expected blood loss. In surgeries where you expect a blood loss more than 500, you can have 4 options preoperatively. Autologous blood donation, where the patient's blood is taken 3 to 4 days before and is preserved so that it can be given on table if required. Now, this is done actually to avoid allogenic transfusion if you expect that the blood loss is going to be more than 500 or more. Second is acute normovolumic hemodilution, where on table you decide that you want to withdraw the blood and transfuse it if required. Again, this is to prevent the infections. Intraoperative and postoperative blood salvage. Now here, if you have the cell salvage machined and you expect that there is blood loss more than 500, around 1000 ml, then it sucks all the blood loss from the operative field or post-operatively from the drains, and then it will wash and give it back to the patient. And prophylactic tranexamic acid. So this measure should be kept in mind when you expect that there could be a blood loss of 500 ml and more. Of course, this is for our surgical colleagues. Suddenly, when there is massive blood loss, as the case scenarios I have explained in one of my case, where it was a simple fist surgery was going on, and suddenly I could see continuous suction noise and my bottle was 250 ml blood filled in my suction bottle. So naturally, alert the team, proper exposure of the area, whatever the surgical team can do, they will do. It could be not only, remember, it could not be just bleeding disorders. There could be a structural cause, a fracture, a bone, pelvic or mandible, or local inflammation. As I've given one example, there was a total abdominal hysterectomy was going on, but there was continuous minor ooze such that 4 mops and 300 ml blood was there in the suction. So it could be just local inflammation and infection, or it could be anomalous vasculature and anatomical anomalies. Now, we have discussed this in much details, the platelet disorders. Now, see, once there is bleeding, which is going to exceed more than 500, all these thoughts should be in your mind. If you do not see a particular cause which is there, no surgical cause as such is there, it could be platelet disorders, Von Willebrand disease, hemophilias, red bleeding disorders, where you can have fibrinogen factor deficiencies, hypofibrinogenemia, or connective tissue disorders. Of course, for each and every patient, though we do PAC, we have to ask for any bleeding disorder, any epistaxis, any bleeding gums, we should include in our PAC papers. Acquired disorders, it is quite obvious. You see the patient with liver disease or any vitamin K deficiency, renal failure, bone marrow failure, chemotherapy, or patient is on antiplatelets, anticoagulant, NSAIDs, immune thrombocytopenic purpures, TIC, factor inhibitors, this should come in mind that though the blood investigations were normal, these are the causes which can cause bleeding. Now, this is a very busy slide. You have to just remember Von Willebrand disease, where we give desmopressin 0.3 microgram per kg. Factor 8 is not easily available, and usually, as Dr. Rachna madam said, they don't bleed, but suppose they bleed, it's like for hemophilia A, as madam said, factor 8, and for hemophilia B, I'll require factor 9 concentrates. But I would like to contradict what madam said, that FFP is not useful. FFP, you just need to give higher dose. Instead of 15 to 20 ml per kg, you might require to give 25 to 30 ml per kg. So what I mean to say, for if you are not ready, if you are not diagnosed the cause and there is a sudden bleeding which has no surgical cause, then think of some bleeding disorder could be there. And in that case, if you are not able to mobilize the factor concentrates, it's always better to give fresh frozen plasma. If you are suspecting hypofibrinogenemia as an obstetric patient or an impending DIC, you might give cryoprecipitate or fibrinogen concentrate. Now, prothrombin complex concentrates are available if you suspect prothrombin deficiency. Again, for factor 5, 7, and 10 deficiency, fresh frozen plasma is useful. For factor 7 and 10, you can also give prothrombin complex concentrate if it is useful. But madam has told us that it is not of much use. Let's see. Factor 11 deficiency, fresh frozen plasma, again factor 13, you can give cryoprecipitate. Cryoprecipitate is also not easily available in private practice. So first thing you have to remember is fresh frozen plasma or prothrombin complex concentrates and desmopressin, of course. Now you have these agents which are there. You have stopped warfarin 5 days before, but still if there is continuous oozing, again, prothrombin complex concentrate, fresh frozen plasma or vitamin K. The dosages are there everywhere. We know the dosages. Only thing, vitamin K will not be useful in acute bleeding. The action of vitamin K starts in 12 hours. Then unfractionated heparin, of course, we reverse by protamine. Everyone knows 1 milligram per 100 units of heparin. This it is effective after 2 to 3 hours of heparin. Now, low molecular weight, is protamine useful? Only partially. So 1 milligram per 100 units of low molecular weight, you can give protamine. Otherwise, the best reversal would be to give fresh, not the best one, but the fresh frozen plasma. Fondaparinux, again, it does not have a reversal agent. We can give fresh frozen plasma. Now, direct 10A inhibitors. They have a reversal agent which is coming in pipeline, which is under phase 3 trial. If I pronounce it rightly, then it is andinaxanate IV infusion, which is available. The doses are there. Dabigatran, now FDA has approved idarucizumab, which is an antibody fragment, which is a direct reversal agent. Of course, it is very costly, and you have 2 vials of 2.5 gram. It is not available here. Now, actually, when the patient starts bleeding and it is not controlled, we try to arrange for blood products. But if you have help at hand, then, and always once the patient is hemodynamically stable, it is better to send the investigations to know what is going wrong. The coagulation profile, the CBC, the fibrinogen, the D-dimers, and of course the other biochemistry. Now, assessment of blood consumption. As I said, do not wait for more than 500 loss. If you see the BP dropping, as in PCNL, once I had after 1.5 hours, the BP kept on dropping, the heart rate increasing. And of course, the respiratory rate was also increasing. Persistent hemodynamic instability is there. Then suspect that there is consumption, blood consumption. Now, which protocol to give is always either 111, this packed cells and FFP and platelet and cryo. Or see, if you give 111, it gives good hemostasis, morbidity, mortality, they say is less. But rather than waste of resources, it is usually, we do not expect that much blood loss, right? More than allowable blood loss, or we think we are going towards it. We start ordering the packed cells. Then we realize that the bleeding is more, or the patient was on anticoagulants and the patient was on antiplatelets, then we might order first the FFP and the platelets. Goal directed is much better. You see what is required and you give it. Your immediate goals, of course, this is only if you have help at hand and you are repeatedly sending the samples, then this could be your goals, but otherwise you have to assess the patient clinically. Clinically see what is the bleeding time, clinically see the pallor, the urine output, the parameters, again same, RBCs, there is no threshold, it's physician discretion, FFP INR more than 1.5. Platelets, usually the trigger is 50,000 and less, unless it's a closed space surgery, and the neurosurgeons and the ophthalmic, and sometimes the prosthetic surgeons, urologists like to give it if it's less than 1 lakh. The cryoprecipitate if the fibrinogen is less. Again, a TEG, which was used all these years, Rotem has come, but TEG we used to give when ACT more than 128 or the angle is less than 65 degrees, then fibrinogen. Everyone knows this, maximum amplitude is less, then you give platelets. Anaphylaxis at 30 minutes, you can give antifibrinolytics. Now I am in an emergency situation where suddenly there is bleeding and there is even it's a private hospital or it's a corporate hospital. For a fracture tibia also, or a fracture femur with hemoglobin of 12, an ASA grade patient, there is no blood is cross-matched. So see to it that at least blood grouping is done. And now if there is excessive bleeding up to 1,000 and more, you start immediately. If you want to maintain the patient's hemodynamic, you start with O negative.
Dr. Tiwaskar, can you please
exceeding.
wind up? Yes, you've
Yeah.
already exceeded the time.
Oh, I'm so sorry. So we know all this about the precipitates and okay, the relative doses of fibrinogen. Calcium, you have to remember when you are transfusing for excessive bleeding, you have to give calcium is needed for the citrated blood. Tranexamic acid is useful in the initial phases. Yeah, so the take-home messages, take a detailed history of the patient. There is no option to it. Ask the bleeding history, preoperative optimization and measures for blood salvage. Think of it. Use of anesthesia and surgical techniques to prevent the blood loss. Low threshold to use blood products and keep them ready. There is something called as cardiac mortality also can occur. 30-day cardiac morbidity and mortality can occur if you have intraoperative blood loss not corrected, and to take care of the other blood chemistry too. Thank you so much. Thank you for giving me the opportunity.
Thank you, Dr. Tiwaskar. That was a very interesting and very useful lecture. And I'm sure everybody will be greatly benefited by the knowledge that you have already shared with us.
Thank you, madam. Thank you.
So our next speaker is Dr. Manjula Sarkar. Madam, are you sharing the screen?
Just a minute, I'm sharing. यहाँ से share करना है ना?
So Dr. Manjula Sarkar is also my co-moderator, and she doesn't need any introduction, especially in this forum. Now, but still, just for the benefit of the people like House, I'm once again repeating that she is a professor and in charge of Department of Cardiothoracic and Vascular Surgery of Anesthesia of D.Y. Patil Medical College, Mumbai. Her major achievements are that she's a teacher for DM Cardiac Anesthesia. She's member of editorial board of 4 journals. She has more than 50 publications and also the author of the Practical Aspects of Cardiac Anesthesia textbook. So Dr. Manjula is going to underscore on the recent advances in the blood disorder. So over to Dr. Manjula Sarkar.
Thank you, Sukanya, for a kind introduction of mine. And today I'm going to talk on the recent advances in bleeding disorders and its anesthesia implications and management. Just a minute. Okay, can you see my full screen? Hello?
Yes, yes, ma'am.
Yes, we can.
Okay, fine. So up till now we heard about the bleeding disorders. What are the different kind of the bleeding disorders? What is the pathology behind the bleeding disorders? What are the involvement of different systems because of these bleeding disorders? What are the prophylactic measures we should take it when we are dealing with these kind of the patients? And what are the different kind of the blood and blood products are available? Those can help us in managing these kind of the patient. So to go ahead with this, I would like to say perioperative hemorrhage may be pre-existing or acquired defect of the hemostasis. Inherited bleeding disorders include different kind of the variety. Hemophilia, Von Willebrand disease is the most common. Care must be taken to keep these factor levels in bleeding disorders at normal level in the perioperative period. Acquired defects due to the oral anticoagulants and platelet inhibitors are common, and we are dealing with these kind of the patients day to day. Quality of blood cells, deficiency of coagulation factors are the major cause of the bleeding disorders, as all of us are aware. Now, this is little difficult slide to explain, but if you know about this slide, then it is easy for us to understand what is the mechanism. So the coagulation might be difficult. The cause of the bleeding may be anticoagulation. The cause of the bleeding may be fibrinolysis, inhibitions, or activation of the bleeding factors. Now, as Dr. Pushkar has already told you about the anesthesia considerations, we can consider preoperatively detailed history, complete blood count, coagulation profile, fibrinogen level, specific factor assay, evaluation for the presence of transfusion-related infection and diseases. Intraoperatively, hypothermia leads to acquired intraoperative coagulation defect. That is the major cause. We should keep it in our mind. Surgeries activate fibrinolytic pathways, trauma, cardiac surgery, and orthopedic surgeries. So these are the kind of the surgeries which can create the problem for all of us. In bleeding disorders, careful use of vascular access and invasive monitoring has already been discussed by the previous speaker. We should keep it in our mind. Avoid of tachycardia and hypertension is must. Regional blocks should be avoided but can be considered if it is needed with due precautions and due prophylactic measures. Post-operatively, early mobilization, consider mechanical deviant thrombosis prophylaxis. Just now one of my colleagues was saying, because early mobilization we do, but we never consider about the deviant thrombosis prophylaxis, and patients are coming with pulmonary embolism, and it is difficult for us to deal with them. So this factor has to be kept in mind when we are dealing with the patients in these scenarios. Avoid non-steroidal anti-inflammatory drugs. Use of blood and blood products to correct the bleeding disorders perioperatively can lead to risk of infection, risk of TRALI, TACO, etc. Hence, correction with the specific factor that is required in inherited bleeding disorder is preferred. Hemophilia has been discussed in detail, so I'm not going to go in detail about that. But just to summarize, I will say 80 to 100% correction of factor 7 before any major surgery. Commercial preparations are available. Cryoprecipitate is a source of factor. Prothrombin complex concentrate can be used. Recombinant factor 7A effective in achieving hemostasis in these kind of the patients in 80% of the cases. So 20% are still is the problematic in our scenarios. Pharmacological solutions has been discussed in detail. Desmopressin, tranexamic acid can give us the good idea, good treatment about these kind of the patients. Perioperative bleeding can involve acquired coagulation abnormalities. Novel approach for prophylaxis and therapy of perioperative bleeding include tranexamic acid, desmopressin, fibrinogen, prothrombin concentrate. Point of care testing of hemostatic function using thromboelastography, thromboelastometry, and platelet function assay allows the specific targeted therapy of coagulopathy. Recently, we have come across in one patient. Patient came to us for the CABG and platelet count was only 60,000. So all other investigations were within normal limits. So we infused the platelets to that patient. 4 packs of the platelets were given and count reached up to 1 lakh and we have taken the patient. On table, patient bled excessively and we were worried why the patient is bleeding. Everything is all right. So we were just giving the symptomatic treatment to the patient, but platelet counts were reducing. Patient got shifted to ICU. The second day platelet count came to 50,000. We gave again platelet. Third day, again the same thing. Fourth day, again the same story. Fifth day, again the same story. So we thought we will take the hematology opinion. So hematology opinion was taken. They said you do the platelet coagulation profile and platelet assay. We did the platelet assay and we found that out of 45,000 platelet, the immature platelet count was 35,000. So only the mature platelet count was 10,000 and we were really worried. All other investigations are all right except the platelet count. So, it is difficult for us to decide what to do now. Then hematology people has advised us to do the bone marrow biopsy, but patient refused to undergo for the bone marrow biopsy. Luckily, the patient symptomatically was all right and got discharged on the 10th day of the post-surgery, but still we don't know what was the cause. So in this kind of the scenario, it is very difficult for us to treat such kind of the patient and how to decide what to do. Multiple factors contribute to bleeding, include blood loss, hemodilution, acquired platelet dysfunction, coagulation factor consumption in extracorporeal circuit, especially during the cardiac surgery, activation of fibrinolytic, fibrinogenolytic, and inflammatory pathways, and hypothermia are the contributing factors. Now, acquired hemostatic defect as a result of oral anticoagulants because of the drug all of us are aware, and platelet inhibitors. Bleeding after surgery include both pre-existing and unacquired defect in hemostasis. Congenital bleeding disorders are less common, but they exist. So we have to keep it in our mind. Antifibrinolytic agents, lysine analogs, we have to keep it in our mind. Now, causes of massive hemorrhage are already been discussed. Preoperative factors, small body surface area, older patients, previous cardiac operations, previous cerebrovascular events, continuation of perioperative use of the drugs, renal or hepatic insufficiency. A pre-existing undetected bleeding disorders, the nature of the operation, the acquired coagulation abnormalities secondary to hemorrhage, hemodilution, hemostatic factor consumption, acquired platelet dysfunction, coagulation factor consumption in extracorporeal circuits, activation of fibrinolytic, fibrinogenolytic, and inflammatory pathways, and hypothermia. Now, if we go for the diagnostic approach for PT and APTT, commonly used conventional laboratory test, PT assesses the functionality of the extrinsic and common pathways. APTT measures the effectiveness of the intrinsic and common pathways. Both tests are valuable as a screening tool for hereditary bleeding disorders. Due to the long-term around time, 30 to 45 minutes, and sensitivity to heparin, these tests for guiding plasma transfusion in emergency post-CP bypass bleeding is limited. TEG and ROTEM technology and clinical applications are very, very useful and very important for all of us. Both ROTEM and TEG are point of care vasoelastic tests used to assess the hemostasis. ROTEM and TEG provides essentially the same information on clot formation, kinetics, and strength. ROTEM and TEG analysis is being incorporated in vertical and algorithms to diagnose and treat bleeding in high-risk populations such as those undergoing cardiac surgery. But limitations are that it is not available everywhere. There are very few institutes, those are dealing with these kind of the equipments, and So many of tertiary care centers are also not having TAG and ROTM. So we are helpless and we can't diagnose the case on this basis. Depiction of the TAG output, if you look for, it produces a comprehensive evaluation of hemostatic function in whole blood, preserving the complex interactions between erythrocyte, platelets, and coagulation factors and fibrinogen. It has shown remarkable accuracy in predicting the post-operative hemorrhage, achieving a success rate of 87%. And different kind of the graphs gives you idea about the deficiency. This is the normal graph. This is the anticoagulant deficient graph. This is the platelet blocker. This is the graph for the fibrinolysis, and this is the graph for the hypercoagulability. Now, what is the rotational thromboelastography? Computerized point of care system that build upon the principle of TAG, allows targeted and dynamic analysis of a specific aspect of the coagulation cascade. ROTM measures the clotting time and clot amplitude, and comprehensive assessment of clot formation and breakdown, enabling the identification of specific abnormalities within the coagulation cascade. Now, ROTM's clinical application, if you look for the normal clot form within 43 to 82 seconds, and it will give us idea about that where the deficiencies. In hyperfibrinolysis and in fibrinogen deficiency, the clot formation will be in the different time. Now, advantages of the TAG and ROTM, the use of vasoelastic coagulation tests such as TAG and ROTM has been found to be more suitable for assessing coagulation during the major surgeries. Now, laboratory and point of care test to predict the perioperative bleeding as per 2017 guidelines, preoperative fibrinogen levels can be helpful in identifying the patients who are at high risk for bleeding. If it is not recommended to routinely use vasoelastic and platelet function testing for predicting bleeding in patients who are not receiving antithrombotic treatment. For patients who recently been administered the platelet inhibitor ongoing DAPT, function testing, we considered the timing of the surgery. Now, multimodal patient blood management, if you look for patient blood management for prediction, for prevention, for monitoring, and for treatment. Now, key points for patient blood management in the intraoperative settings are a restrictive RBC transfusion policy is not inferior to a liberal transfusion policy in cardiac surgery patient and in major surgical patient too. Intraoperative hemodilution should be used on an individual basis only in patients with a high preoperative hemoglobin levels. Coagulation therapy should be personalized and guided by the algorithm. Administration of fibrinogen optimizes the coagulation, but should not be routinely given as a prophylaxis. So prophylaxis use of fibrinogen is not recommended. Now, fibrinogen concentrate is also available. Recently, we are launching the fibrinogen concentrate. Plasmagen company is launching it, and it is going to be available soon in the market. And whenever we are in problem and we are not in very much safe situation, we can use fibrinogen concentrate in limited doses. Protamine to be used as a ratio of 1:1 for the cardiac surgery patient. There is no evidence supporting the standard use of protamine in cardiac surgery. Considered is a case of uncontrolled bleeding with no other therapeutic options. Now, this is the Duke intraoperative transfusion algorithm for the cardiac surgery patients based on the point of care hemostatic testing for high risk patient. But this is only for the cardiac surgery. And I really don't know how much it is going to be useful for other surgeries, but because in this algorithm, the specific point has to be taken for the cardiac surgery and during the cardiac pulmonary bypass or during the after cardiopulmonary bypass, how you are going to manage the cases. Now, post-operatively, what should be followed? Chest tube drainage, if it is more than 200 ml per hour, consider exploration. Yesterday only, we have re-explored one patient. The patient was bleeding 300 ml per hour. We have given the tranexamic acid, we have given the blood, we have given the FFPs, cryoprecipitate, all the blood products prophylactically, but still bleeding was not getting controlled. So we have taken the patient for exploration. And inside the pericardial cavity, there were a lot of clots. There was no frank bleeder. There was no artery which was bleeding. So we really don't know. But exploration has helped, and clots were removed and patient stopped the bleeding. So bleeding exploration has to be considered if the drain is having more than 200 ml per hour. Transfuse platelets, cryoprecipitates, and RBC based on the laboratory correct fibrinogen level, depending on this algorithm. Now, hemostatic monitoring throughout the perioperative period and possible treatment modalities which are available. Preoperatively, identification of the patient at a high risk of bleeding. If patient is having anemia, treat anemia. If the patient is having nutritional deficiency, treat nutritional deficiency. If fibrinogen level is low, then you have to treat the fibrinogens. Intraoperatively, maintenance of hemostasis and minimizing the blood loss. Meticulous surgical hemostasis is must, because most of the time in hurry, most of our colleague surgeons are not achieving the proper hemostasis and they feel they have achieved it, but post-operatively patients are bleeding because of the hemostasis was not achieved properly. Minimizing hemodilution, individual heparin and protamine in cases of the cardiac surgeries, normothermia maintenance, prevention of fibrinolysis, use of cell saver. As Shilpa has already told you, cell saver really helps us. ACT heparin or FXA measurement, patient warming, maintenance of tissue perfusion, tranexamic acid, aprotinin, EACA are helpful. Most of the time, most of the centers are using this, but most of the centers are really not using. So this use of aprotinin and EACA is controversial. Post-operatively, perioperative treatment algorithm for bleeding patients. Insufficient fibrinogen level, give fibrinogen. Low platelet count, give platelets and treat anemia. Intraoperative targeted transfusion algorithm in cardiac surgery patient, perform ROTAM or TAG during rewarming phase of the bypass. Heparin, rule out for the residual heparin, restore the platelets, restore the fibrinogen, replace the factors whichever are deficient, and restore the fibrinolysis. Continue antifibrinolytic agents, mini circuits use, retrograde priming, and cell saving is important. Intraoperative targeted transfusion algorithm, if non-tech or ROTAM directed, we have to look for in the presence of excessive microvascular bleeding. If hemoglobin is less than 7.5, transfuse blood. If platelets are less than 50,000, give platelets. If INR is more than 1.5, treat accordingly. If fibrinogen is less than 150, give fibrinogen. So current treatment options available are packed red blood cells, fresh frozen plasma, platelet concentrate, cryoprecipitate, fibrinogen, recombinant factor, tranexamic acid, prothrombin, antidotes, and desmopressin. This has been already told you about by previous speaker. So what are the different disadvantages of currently available treatment options, right? Treatment options are available, but what are the disadvantages? So packed red blood cells, a larger quantity of RBC unit increases the likelihood of developing acute lung injury, common. Age of stored red blood cells is linked to increased risk of respiratory failure that necessitate extended ventilatory assistance. Platelet, higher risk of infection and sepsis and death. Tranexamic acid can cause seizures, headache, backache, abdominal pain, nausea, vomiting, diarrhea, DVT, and anaphylaxis. Prothrombin concentrate causes the complications. Blood products used for management of massive hemorrhage, type of product, FFP, and cryoprecipitate. These are the commonly used products. So if we compare this, the source of product, human donor, derived from FFP. The method of viral inactivation not done. Viral inactivation is not done in both the cases. quantity of fibrinogen in the product, low efficient fibrinogen, effective fibrinogen concentrate. So when we are expecting there is a less fibrinogen, you have to give the cryoprecipitate. But the availability is a big question mark. Dosage recommendation, standard dose 12.2 ml per kg, a less accurate and varied dose of fibrinogen, single dose 400 to 600 milligram fibrinogen and dose adult 2 into 5 pooled units. Time of reconstitution of the product, high thawing time and thawing required for 70 to 20 minutes only for the cryoprecipitate. Now, ABO compatibility, blood group preferable, blood group matching preferable. Transfusion complications are more with FFP rather than cryoprecipitate. Shelf life, low shelf life, 1 year shelf life for cryoprecipitate. Content of the product, all factors are present, factor 7, BWF and fibrinogen actin also present. So that is more beneficial. Recovery of fibrinogen in vivo fibrinogen recovery 50% to 60%. Safety issues withdrawn from same European countries due to many complications and concerns. If you look for the disadvantages of cryoprecipitate, no viral inactivation, potential risk of pathogen transmission, variable fibrinogen level, accurate dosing is not possible, infusion volume lower than fresh frozen plasma, but higher than fibrinogen concentrate. Must be thought before infusion, ABO compatibility is required. Disadvantage of fresh frozen plasma, safety risk, high volume, logistic complexities, limited supply, increased risk of morbidity, and positive effect. So to summarize, I would like to say bleeding in cardiac surgery can have multiple causes, even for other surgeries too. The use of viscoelastic coagulation tests such as TEG and ROTAM has been found to be more suitable for assessing the coagulation during major surgeries, any major surgery. Preoperative fibrinogen levels can be helped identifying the patients who are at high risk of the bleeding. When we don't know the cause of the bleeding and we are not able to diagnose the patient, why the patient is bleeding, then fibrinogen may help by considering this is the factor 1. Blood products like cryo and FFPs are commonly used, but they have their own limitations. So we are just waiting for the fibrinogen concentrate to come in the market, and let's see how it is going to help us. It is going to be on the trial basis. I have used a fibrinogen concentrate in 2 of my patients during cardiac surgeries around 8 years ago. But those patients were diagnosed cases of the fibrinogen deficiency, and I got the fibrinogen concentrate from the Hopkins Institute. And those patients were lucky and they just went home safely. So thank you very much for your patience hearing. And I'm sure that we are going to be in better position and deal with better ways these kind of the patients in future.
Thank you, Dr. Manjula Sarkar, for your lecture on the recent advances. And also, I thank you for sharing some of your practical experiences and case scenarios. I'm sure everybody will be benefited by that. So we are at the end of all the talks, and I take this opportunity to thank all the speakers for their excellent talk. And we are now going to have our question answer session. As a moderator, I can see there is one question in the one or two
chat box.
Yeah. One question in the chat box, and so this goes to Dr. Tiwaskar, and the question is that, is there any role of routine bleeding and clotting time before regional anesthesia?
There is no need for routine bleeding time or clotting time before regional anesthesia. But if you suspect the patient was on some anticoagulants, or the patient was taking ecospirin, or the patient is CKD patient, you might do a bedside bleeding time yourself.
Yes. So routinely bleeding time and clotting time does not have much role. But of course, they do have a place, as Dr. Tiwaskar has already underscored. I don't see any more questions in the chat box. So if anybody has any question, can you please, you can unmute yourself and speak up, like ask the question for the speakers, and they'll be happy to answer this.
May I? I wanted to know the experience of the speakers, if anyone has used PCC or if anyone has used any concentrates, factor 7 concentrates. But I haven't personally used it.
So that is Dr.
We have
Tiwaskar's
used
question.
factor 7 in cardiac surgery, but not concentrate. It's under Novo 7, and it's usually as a end stage last resort, you can say, but it works wonderful. Of course, it's not recommended in cardiac surgical subpopulation, but there are many anecdotal case reports as well where it has been proved that it helps. But still, we don't have a class 1 or class 2A evidence for it.
Okay, thank you so much. Because we discussed so much about the therapy, so actually what is practical even in an institute or in a private practice? Because I was in a private practice and for last 11 years in an institute, so it's the same nearly.
Can I comment here something? Recently, I have met one of the anesthesiologists who came from Germany, and he was talking about the fibrinogen concentrate. And as per his experience, he said when the patient start bleeding on table because of whatever is the reason, his first approach is to give the fibrinogen concentrate in due doses before giving any blood or blood products. So I asked him, is this related to only in cardiac anesthesia or any other patients coming for any other surgery, or the cardiac patients coming for the non-cardiac surgeries? Because problems are arising when the cardiac patients is coming for non-cardiac surgeries, and most of the time they are on some antithrombotic drug or thrombolytic drugs or antiplatelet drugs, or that such kind of the things, or with a stent or without a stent, or there are so many problems. So he said, no, his approach is that whenever any patient start bleeding on table, first he gives the fibrinogen, and then he thinks about giving any other blood and blood products. So I asked him whether we should treat that this fibrinogen concentrate as a prophylactic measure, and can we give it for the preoperative time for optimization when we are expecting any bleeding. Suppose the liver disease patient is there, when we have to give the vitamin K or FFPs, or any renal surgery patient or any other patient when we are expecting. So he said, no, you can't give it for optimization in the preoperative period. You have to think only if the patient is bleeding on table. So I said, bleeding on table is all right, but when we know the acute hemorrhage is there because of whatever is the reason, we have to replace with blood. How can you give the fibrinogen? So he said, no, that in our institute, the approach is like this. So I said, okay, fine. That is why the India is considering to launch the fibrinogen concentrate, and you have captured this company to launch it. So no, not like this. So I'm really still in doubt whether, that we should consider or not. But according to them and according to their evidences and their references and their review and their case scenario, it helps.
More in obstetric patients?
I asked regarding obstetric also. So obstetric patient, he said it is not going to help because obstetric bleeding is a reason is different. That is hormonal bleeding. That is because of the placental insufficiency or estrogen or progesterone, whatever is the reason. So that is not going to help in the obstetric patient. He said it is going to help only in the cardiac patient where the cardiac drugs patients are receiving, or in the liver disease patients where the liver is defective and coagulation profile is different because of the production of the clotting factors, or it might help in the renal
deficiency. If fibrogen deficiency is there, then obviously it will work.
No, it will work in fibrinogen
Yes,
deficiency.
ma'am.
But
On
it will,
DICs also, I think it will be effective.
so I really don't know, because we do not have any case studies
Madam,
like this. with us.
cost, how much is it?
Cost has not been decided yet.
First,
They are
it's
deciding
availability.
soon,
First,
and
it's
I'm sure
availability.
I
I'm
think
sure that it is going to be available soon. He said they are going to launch somewhere in the last week of the July or the first week of August. And some Bangalore company, Plasmagen company is producing.
thank you, Dr. Manjula, for about the new, modality for controlling the bleeding disorder. I see some questions in the chat box, and this one is from Dr. Sanish. He has asked the role of tranexamic acid in a patient with pre-existing hematological disorder. So, can anybody take that question?
See, in pre-existing hematological disorder, tranexamic acid is going to help. We are using tranexamic acid as a routine for all our patients where we are expecting bleeding. So usually we give for optimization on the previous day of the surgery, preoperatively before induction and after the surgery. And even in the post-operative period when bleeding is not getting controlled and blood loss is more, first we give tranexamic acid and it helps, unless there is a surgical bleeding or iatrogenic bleeding.
Okay. Dr. Sanish, are you happy with her response?
I think one more question in the audience.
Yeah,
Q&A.
I'm going to come to that. I thought that maybe if you're okay. So I come to the another question is that what were the, this is by Dr. Muthukumar Rajagopalan. And the question is that what were the measures used to maintain the temperature for 20 hours?
I think that that is a question for our previous webinar. I think the question is role of tranexamic acid in patients with pre-existing hematological disorders.
I think
That I have already answered.
Answered that was already discussed, Dr. Sanish.
Okay, fine.
Yeah.
That's
So I don't see any more because as I guess that this must be for previous, because it's regarding temperature and where it was measured, pediatric anesthesia in a patient with craniostenosis, synostosis, I guess. So I believe there are no more questions in the chat box. So I have a question for you, Dr. Desai. Can you please highlight a little bit on directly acting oral anticoagulant drugs? Because that is, they are of aesthetic concern.
Unmute.
Dr. Desai?
Pushkar, unmute. Yeah. You are audible.
I could not hear your question clearly.
Sukanya, please repeat question. Sukanya, please repeat your question.
I was asking, am I audible?
Yes, you are.
Okay, so I was asking Dr. Desai to highlight upon the directly acting oral anticoagulant drugs. The newer oral anticoagulant drugs.
NOACs, right? Madam, you are saying
NOAC, yeah.
So highlight in terms of what highlight, ma'am? I did not get your question.
Newer anticoagulant. Newer anticoagulant drugs.
I wanted to know about your anesthetic concerns about newer oral anticoagulant drugs.
So, ma'am, actually, this newer anticoagulant, they are still mainly been followed in cardiological subsets and very high risk patients who are in atrial fibrillation with high risk of thrombogenesis. So in dealing with these subsets of patient, you have to find out the you have to go with the pharmacological prescription of the patients. And majority of these patients, they do not have any reversal agent. Okay, so we have to find out as per the recommendation. I think in the webinar, I think there was one slide where it was came like dabigatran and all, and some experimental new antagonist it has come. So idarucizumab and adixabetan and something like that. So I think we have to keep in mind about those agents. But the best way in those subsets is to wait for elective cases, and generally we wait for 48 hours. For different agents, so there are different half-life, but it's as a rule of general rule, it's better to wait for 48 hours in those cases. For emergency, we have to take up the cases and then we have to go as per the rotem and take, and then whatever is discussed during the webinar. We cannot help in that. And it is a very stormy course, of course. In our cases, in our subsets where we take these patients for very urgent CABGs and all, we usually do the platelet mapping first, so that we get to know that how much the platelets are inhibited at the same time. So accordingly, we can prepare the blood bank and we can ask for the support in a timely manner.
Dr. Desai, just a comment that new oral anticoagulant drugs, they have a very short half-life, and therefore, they are very useful compared to the normally used warfarin. But the one concern one has to keep in mind is that, yes, 40 hours, 4 to 40 hours, but this is a renal failure. I think this should be stopped for more than 72 hours because
Dr. Sukanya, I have a 2022 guideline on the newer drugs. I can briefly talk about it.
I think rivaroxaban is the most commonly used drug here as a NOAC, and for that we usually wait for 48 hours.
We also wait for 48 hours.
It has a half-life of 5 to 9 hours. Depending on whether the surgery is minor or major, we withhold it according to that. So 24 hours for a minor surgery, we can withhold it. And if it's a major surgery, we withhold it for 48 hours. And after the minor surgery, we can restart if we want to restart the drug after 24 hours, if it's a minor surgery. The same applies for major, 48. So similarly, for epizaban, edoxaban, betrizaban, and dabigatran. Now, when it comes to betrixaban, it is more than 4 days you need to stop for a minor surgery or major surgery, it's the same. Whereas dabigatran, you need to at least stop 72 hours prior for a minor surgery and 120 hours prior for a major surgery. Whereas because half-life is very important. Betrixaban, it has 19 to 27 hours of half-life. So that half-life.
So factor 10 inhibitors, I think it is 48 hours, and the others it is 72 hours, right?
Again, depending on whether it's a major surgery or minor surgery, and the half-life. Taking into all three factors, you can consider it. Warfarin, definitely you have to withhold for 3 to 5 days.
Yes, well said. Just I wanted to, since we were discussing about anesthetic concerns, so when the patients are having a deranged renal function, one needs to be more careful with the newer oral anticoagulant drugs because they're primarily excreted through that. And as we mentioned about warfarin, one more thing is that now again, as Dr. Sweety mentioned about the 22 update, they have also mentioned that warfarin need not be stopped for minor surgeries. Why? Because the chance of, it has been seen that once they're restarted, there's a more chance of stroke due to the procoagulant effect. So that is also one of the drawback of warfarin, and I'm sure the newer oral anticoagulants are going to be the mainstay in the patients in the perioperative period. I would,
sorry.
yes.
Such newer and NOACs, they are hard. They are very reserved for patient with borderline renal function. So in practical, you don't see patient having borderline renal function and having on rivaroxaban or something. So primarily they are not put on. So if patient has NOAC, we can safely consider that renal function is adequate.
Well,
What are the chances
just
of, sorry.
I differ.
Okay, fine, Sukanya. I think the
okay.
discussion is going to be never ending, and everybody can follow the newer guidelines. And you just conclude. Dr. Radhakrishna is waiting for giving the vote of thanks.
Yeah, just one thing I wanted to put that these newer oral anticoagulants are used very rampantly in our setup in Chandigarh and in northern part of India. So I think even for the benefit of the house and the students, like people should be aware of their concerns and their half-life. Especially when they need to be stopped before
So we will
surgery.
request Dr. Radhakrishna to give us one more webinar for the anticoagulants.
Before that, Manjula, the doubt is Sukanya is telling something and Shilpa is contradicting. What I'm saying is that is it institutional practice or national protocol? Are it telling the institutional practice?
Yes, sir.
Hello? Are it
yes,
telling the national protocol or institutional practice? Because you are telling about the timings, 2 days, 3 days, something like that you are telling. And is it for your institution or is it a nationally approved protocol?
No, sir, she is saying as per guidelines.
Guidelines.
Yes,
Which guideline?
48 hours we
Which
wait.
guideline? Which guidelines?
This is up to 2022 guideline. This is perioperative guideline on antiplatelet and anticoagulant agents 2022 update. This has been published in circulation.
Is everybody following that? Or
Well,
are
it has just come. It has just come, sir. So, I mean, it needs to be, widely followed.
It needs to be followed, but people are starting only. Okay. And now, Manjula, your fibrinogen concentrated, that is a German protocol or is being used everywhere now?
No, according to them, they have done a lot of studies in Germany and it is used at many countries, and they are now recommending to use in India also, and they are just circulating the samples and product and literature. So soon we are going to start the trials, or we will just use the samples and see how it is going to work. And up till now, it is only in literature for India is concerned.
So simple. The protocol is forced on us. Okay.
Yes.
Okay, let us see what will be the benefit. Anyway, thank you very much. This was a
So I think we are at the end of the session, and this is the time for dinner for all of us. And if there...
as Manjula was telling, well, if needed, we will have one more debate. On the blood disorders and anesthetic complications. Sometimes say after 2 months or so, which are the areas we left out now, it could be taken, especially well, we had to take the smaller age group as well as the older age group. There also there are some obvious instabilities going on. And I thank you very much on behalf of the Indian College of Anesthesiologists for participating and making us know about what is the current national guideline or the protocol. Thank you. Good night. And we'll see next Wednesday. Next Wednesday is our 3rd annual, that means completion of 3 years of webinars. And as you know by now, here what we're going to do is that some of the selected articles from anesthesia journals are picked up and will be distributed to you all soon. And the primary authors of all these particular articles will be talking to you and how they came to that particular article formation. Okay, so we hope that's going to be interesting and again a new sort of discussion. And thank you once again. Good night.
Thank you, sir. Thank you,
Good night,
Manjula.
sir. Thank you, Manjula madam. Thank you, Mitra madam.
Thank you, Sweety.
Thank you so much. Thank you all
Thank you,
colleagues.
Shilpa.
Moderators and panelists around here.
Thank you, Richa.
Thank you. Thank you so much, everyone, for sharing your valuable insights and for being with us on this platform. Hoping to meet you again on this platform very soon for the next sessions. So with all your permission, we are concluding the session over here.
Thank you.
Thank you.
Yes,
Thank you so
thank
much,
you.
Ankita.
Thank you so much, ma'am. Thank you. Thank you. Take
Thank
care,
you.
everyone.
Thank you.
Thank you.
Bye.
Bye.